I'm David Leonhardt. I'm currently the Washington Bureau Chief of the New York Times. I'm formerly an economics writer for the Times, and I spent a lot of the last few years writing about the whole battle over the health care law. Before that, I spent a lot of time writing about health care before there was a law. And I'm your moderator this afternoon. You really have three wonderful folks to talk about this law. And we're each going to talk very briefly, less than 5 minutes each, I promise. And then we'll have a short discussion among us. And then we'll open it up to you all to hear questions and comments from you all. And I probably don't really need to introduce the topic. It has been the topic that everyone has been focusing on, not only this week, but much before it, which is the healthcare law, the state of healthcare, and I think you'll hear from us, we're all really going to emphasize where do things go from here. I'm in fact the only one in my brief opening remarks who's going to really focus on the past, which is I'm going to try to give you the shortest summary of the ACA or Obamacare that has ever been delivered.
And when that works, we'll show the campaign.
So I'd say it has four major parts. The first major part is it vastly expands insurance coverage, and it does it through two major ways. About half of the expansion in insurance coverage is the stuff that's gotten all the attention. It's the mandate. The law says all Americans who can afford it must have health insurance. And to help them get it, it sets up these marketplaces where you can more easily compare and see health insurance. And then it subsidizes anyone of moderate income. In the medium term, that should cover about 17 million more Americans, or about 1 out of every 3 people who would otherwise not have insurance. The second big part of it is Medicaid. They take Medicaid, which is now a big, complicated mess. Depends on where your income, what your family situation is, and it sets a standard on it. As long as you are, I think, 133% of poverty level or below, you qualify for Medicaid. Big expansion of Medicaid. That's the second half of coverage expansion. That covers another 1 in 3 people who don't have insurance. That still leaves 1 in 3 people who won't have it, a kind of mix of, not 1 in 3 overall, but in that pie, a mix of illegal immigrants and people who do not want to have insurance. That's part 1 of the law, expanding insurance coverage. Part 2 of the law is paying for that through taxes, a combination of taxes on high-income people, raising their Medicare taxes, and also taxing companies. That's part 2 of the law. Part 3 of the law is, over the long term, trying to bring down the spending on health care. And I think you'll hear Emanuel talk a lot about this, and I'll introduce each one of the 3 of them once I'm done. And so the idea with that is that people want to bend the curve, as Peter Orszag and Zeke and lots of other people often say, which is to say they want to reduce the growth rate of healthcare going forward. And the law tries to do that through a variety of ways, trying to change incentives in healthcare, sometimes trying to just cut spending of overall healthcare. That is part, wait a minute, I've got my numbers mixed up, right? That's part 3 of the law, and what's part 4 of the law?
Well, all the quality stuff, reduce hospital readmissions,
right.
Improve
the quality of healthcare, regardless of whether it's financial or not. So try to have a healthcare system that not only doesn't grow at the same speed, but also provides better results. Because right now we spend more than any country in the world by far, and we do not have better results than any country in the world by far. It's a mixed bag. We're better at some things, like some forms of cancer care. We're worse than others. So that's the law. 4 parts: cover more people, pay for it, try to reduce the deficit over the long term, and try to improve the quality of healthcare. The Supreme Court effectively upheld every single part of that law with one significant exception: the Medicaid expansion. They made that optional for states. So if you remember, I said about half of the expansion in coverage comes from Medicaid. So if every state opted out of that expansion, which is an option the Supreme Court just gave them, the law would only cover half as many people as it otherwise would have. No one expects every state to opt out of it. The blue states will not opt out of it. It remains unclear whether the red states will. You'll hear all of them talking about that today. But basically what the court said is that somewhere between 50% and 100% of the healthcare coverage expansion that goes on may continue, and parts 2, 3, and 4 of the law may all continue. So that's the Affordable Care Act. You can see why people would not put it on a bumper sticker. But there it is. And the question is, where do we go from here, both legally and otherwise? And to talk about that, we have Neera Tanden, who is the chief executive of the Center for American Progress, one of the most important research groups in Washington. It leans left, or leans progressive, as Neera might prefer I say.
We go with progressive.
Neera is previously the chief policy advisor to Hillary Clinton during her campaign. After that, she was the chief domestic policy advisor to Obama in the general election. and she was then a top advisor to Sebelius in the making of the healthcare law. Tyler Cowen is a professor of economics at George Mason University. He's the author of the extremely well-read Marginal Revolution blog, co-author of it. He also is maybe the single best source for good food in Washington. He writes a blog. If you are ever looking for a restaurant in Washington, just Google Tyler Cowen restaurants. And he's the author of a new book, An Economist Gets Lunch. And Emanuel is the former head of bioethics at NIH, is a former advisor to Peter Orszag and to the president at the budget office, specifically on healthcare, and is now a vice provost at the University of Pennsylvania. We're going to start with Neera. I've done the past. You guys get to do the future.
Great. So I think I'll talk a little bit about the decision and what it means. Essentially, just to summarize for those who have not read about it recently, the decision says essentially that the mandate, the issue that got the most attention in the deliberations, is constitutional. Chief Justice Roberts found that it was unconstitutional. I mean, it was not constitutional via the Commerce Clause, which I think it is fair to say had the most amount of energy around it. There are two arguments around the Commerce Clause. It's just it's a necessary and proper. There's a necessary and proper argument and just a straight Commerce Clause. But under both findings, we could talk more about them. Under both findings, he found that it was unconstitutional, did not pass constitutional muster. However, he found that it was constitutional under the taxing power of the federal government, which is interesting in that no lower court found it constitutional under the taxing power. Now, part of that is because courts that found in favor of the law found in favor under the Commerce Clause and therefore didn't reach the taxing power. There was only one judge, Judge Wynn in the Fourth Circuit, who actually said it was both constitutional under the Commerce Clause and adjudicated, but that was not the majority opinion. So it was quite a day on Thursday to find that that was indeed the rationale. It was argued by the Solicitor General. It was in the Solicitor General's briefs, but it was not a persuasive argument in the lower courts. So that is the argument that it was found unconstitutional. Now, on the Medicaid issue, as David said, the Medicaid expansion was found constitutional, but the authority by which it can be the power of the federal government under Medicaid was limited. So what the court said really was that the federal government cannot use the entire Medicaid program as the leverage point upon states. So as we all know, Medicaid has existed for 40 years. It provides a subsidy of between 50 to 83% to states to provide coverage for this amalgamation of people. In some states, it's relative. It's not. I wouldn't describe it as generous, but it is more generous in other states. Some it is only the exceedingly poor. Others are bringing in more working poor people. But that essentially said to the federal government that you can't use the existing Medicaid subsidies to cover it. So right now, states have a Medicaid expansion before them, which they can choose to expand or not. For the first several years of implementation, it is 100% match. So let me just say that again. For every dollar the state expends, it receives $100, 100% of federal dollars for it. It expends no money in the first few years. It declines to 90%. Now, what I find interesting about that, and I will just discuss it for one moment because I would like everyone else to speak, is that what is interesting about the courts, how it has approached Medicaid, it is seemingly more concerned about a regime that provides a 90%, 100 to a 90% match than it has ever expressed about a regime that was 50 to 83% match, which I find an interesting and odd outcome of the litigation. And one of the reasons I believe that judges are sometimes, it's hard to adjudicate policy issues in the courts.
Excellent, thank you. Tyler?
I'll try predictions. Let's say Obama wins. I think the key to the future is to keep one's eye on the Medicaid issue. I don't think the Supreme Court ruling on Medicaid is itself important. I think the governors, once they stop making noise, will leap on board. But the public itself doesn't know how much of the bill's coverage comes from the Medicaid expansion. So you hear mandate, 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 but Medicaid is quite an unpopular program, and the state governors have financial incentives over time to want to push people onto the subsidized exchanges. So I think we'll see a huge tug of war between governors at the state level, including Democrats, I might add, who would rather spend money on wealthier and more influential voters, and the federal level, where there's an incentive to keep people on Medicaid and away from the subsidized exchanges in too great number. And who wins that tug of war is, to me, the key question. I'm not sure. I think what is probably the best available outcome is for over time, if ACA moves to something like a means-tested voucher system, where most people are buying on the exchanges. Zeke has written on this. I would favor that, but the problem is the way the exchanges are set up now, that would be too expensive. There's even a part in the bill that says in year 2018, if so much is being spent on subsidies through the exchanges, it has to be cut. So I'd like to see it evolve into something where you have catastrophic coverage on the exchanges and a mandate which is really extremely modest relative to a lot of current expectations. And then for cheaper expenditures, have something more like a market competition system. And I wouldn't quite say that's a prediction, but that's one path through which the law could evolve into something quite different. Now, say Romney and the Republicans win and also take the Senate. That's a harder set of predictions, but my gut feeling is they don't actually want to have to replace. That's a huge embarrassment for them. They wouldn't know what to do. There are tax credit plans. Maybe in the abstract they make sense, but you spend more money to achieve kind of the same result, and the fact that you avoid the M word sounds great in a campaign, mandate M word, but doesn't do them that much good in terms of doling out benefits to people who actually vote and support them. So my guess is they'll pick on a bunch of parts, get rid of them, and declare victory. And the key problem for them is they can't just leave the mandate in place. There's been so much talk about the M word, and I don't know how they'll get rid of the mandate in words without getting rid of it in practice. I'm personally not creative enough to figure out how this will be managed, but my prediction is they are more creative than I am. And if Republicans win everything, we'll end up with more parts of the law than you might think hearing the rhetoric today. Anyway, I think my time's up.
Thank you, Tom.
So let me say a word to pick up where Tyler said. If you look at the Medicare situation going forward, it really is perfectly economically rational for every state to adopt the Medicaid program because, as Neera said, they get 100% in the first 3 years and it declines to 90% of the cost being borne by the federal government. So a state has very little money going out. Not only does it have little money for getting more people on Medicaid, it actually is going to save money because first, every state now has what's called a cost shift. It buys insurance for its state workers, and buried in that insurance is actually payment for uninsured people. And so that will go down. In addition, every state has some program for paying for the uncompensated care that people who are uninsured have. That will go down when people have insurance. So from an economic rationality standpoint, and actually the Council of Economic Advisors analyzed this in September '09, it makes perfect sense for every state to go in and adopt the Medicaid. The only reason I can think of that they wouldn't is ideological. We don't want to do it. We don't want to expand. You know, you might think that Texas or Florida will decide that this is, more federal program, even if it would make sense for the state from an economic standpoint. And we've seen a lot of that sort of behavior where it's not in their interest, but they do it anyway. All those states which want state control of the exchange and yet haven't invested a nickel in getting the exchange up and running are not going to run their own exchange come next year when they have to go live. Let me talk about, David said, I'd say a word about cost control. Cost control is extremely important whether you're a liberal or a conservative for the following reason. If we can get healthcare costs to go moderate, and they have moderated, by the way, over the last few years, then the cost of the subsidies go down. The cost of Medicaid goes down. The cost of Medicare not goes down, but stays lower as a portion of the budget. And for private employers, obviously, they also have moderated healthcare costs. It is a huge advantage to every sector of the economy if we can actually moderate the healthcare costs. Now, I spent a lot of time working with Peter Orszag, who's somewhere over here, on the bill and trying to get a lot of this cost control in the bill. And I'd say that we got a lot of things, but one of my big frustrations is we did not get enough deadlines on cost control. So there's deadlines on the mandate. You know, the exchange is open 2014. There's deadline expanding Medicaid. There's lots of other deadlines. But on the cost control, we didn't get as many deadlines as we should. And that is very important because big health systems need to understand when things are going to change to schedule their investment and to see that it's real. I think what you're going to see going forward is a real focus on this cost control because of its effect on the budgets and its effect on private employers. And if you're very interested from a standpoint of getting more people insured, it's also in your interest because the more the costs go up, the more precarious this whole arrangement is. And so I think, again, whatever your stripe, liberal or conservative, Democrat or Republican, going forward, that really has to be a top priority for you because it's the only way the system is going to be able to keep stable.
Neera, you want to jump in?
Can I just make two follow-on points to Zeke? First, on the Medicaid point, there is a sort of political economy problem on Medicaid, which is Zeke is absolutely right that states save a lot of money from the Medicaid expansion because they pay a lot of costs right now for uncompensated care, and they'll get a lot. That will all be paid for, 90% paid for. The problem for some states is that the challenge is that occurs often at the municipal level, at the city level. So Florida is a perfect example. Florida at the local level has a number of programs. Miami-Dade County pays $170 million or something like that for uncompensated care through a tax it pays at the local level. So Florida overall will save, but it's not entirely clear how much Governor Scott will save. So I would say as a good leader of a state, you should care about both the state level costs and your municipal costs, but it's not entirely clear that every governor will think that way. And I think that will be a friction. Hopefully, I know there's some mayors in this audience that, mayors will recognize that they are also bearing the brunt of these costs and they get a big windfall, and I hate to use the term windfall, but a big windfall from the Medicaid expansion. On the issue of costs, I agree with Zeke on the overall issue of how this is a drain on our economy and we need to get going on costs. The challenge that we saw through the polarization of the debate, and Tyler wasn't one of these people, but there were a number of people. I mean, the truth is that for decades it was Republicans who were leading on cost control issues. And there were a number of Republican senators who had been strong advocates of cost control issues. Comparative effectiveness research was an area in which there were Republican senators who had been who had shown greater leadership on that issue. The challenge with the debate is that it became so polarized that those same senators made cost control, basically they called it rationing. And it hyper polarized the debate. And my hope actually is that now that we've gone through the Supreme Court and we've seen, we've had a final affirmation around this, that hopefully we'll see some of those Republican leaders come back to the fold and demonstrate that leadership. I will say many of them were better than Democrats on this issue, but that's one of the reasons why we didn't get stronger cost control in the legislation, and I believe there is strong cost control in the legislation, but maybe we didn't get stronger cost control as it was only Democrats. And arguing within ourselves did not provide enough leverage points because it would have been really helpful to have Republicans pushing, but they walked away from the whole bill and were really attacking things like comparative effectiveness research as rationing in a way that made it difficult to make those decisions, not easier.
Let's spend just a minute on the politics because you all, I think we're sort of predicting that. You used the phrase final affirmation. Tyler, you said that the Republicans, if they find themselves in office, aren't going to repeal everything they say now. I guess I want to get you to go into a little bit more detail on that because that's not clear to me, right? The history seems to show that what people campaign on, they do, right? And Mitt Romney's campaigning on repealing Obamacare. He appeared before a sign that said "Repeal Obamacare" the day of the Supreme Court ruling. The House
repeal and replace, I think it said.
Okay, the House is again going to repeal Obamacare sometime soon, right? They're going to vote again. So I guess let's imagine a world with a Romney presidency, a Republican House, and a slight slight Republican majority in the Senate, which I think if you're imagining a world with a Romney presidency is probably most likely. It's certainly entirely plausible. How in that world is a world in which they don't deliver on the promises that they made, right? In which the Republicans come out and they repeal through reconciliation. They need only 51 votes to do the budget. They get rid of the Medicaid expansion. They get rid of the subsidies, and then you're left with the sort of little insurance market reforms, like about 24-year-olds being able to stay on their parents' insurance. How does
first
that
of
not
all,
happen?
it's always a lot easier to take a symbolic vote that has no significance and you know will die, like the House taking this vote on repealing. I think that they're not going to be able to do, I think Tyler is right, they're going to do something, they're going to call it repeal, but it's not going to be full repeal because, first, there is this budget problem. That is, the health bill actually saves money over the decade, and they would have to find money to fill that hole, and they can't find that money. Second, it puts them in the pickle of the replace part of it, because a lot of the bill is popular, like the insurance reforms and the keeping kids on until 26 and many other things, and you're going to have to then have a full set of policies, and the Republicans don't have a policy. We learned all through the debate that they had lots of things that they would argue about, but it was never a policy. It was never a whole thing that addressed the problems of access, cost, and quality. The last point I would make is Romney is going to need cost control, just like everyone else, for budgetary reasons. And I don't think he can throw out the whole bill because of that. He's going to have a mechanism to keep healthcare costs down because he's going to have to get the budget into some more reasonable balance. And healthcare, as you know, because you've written many, many articles on it, is the long-term threat to the federal budget. And it's even a medium-term threat to the federal budget. So I just don't see, I mean, I think Tyler's right. They'll do something. It'll be relatively modest. They'll call it repeal, but most of the bill is going to proceed.
This is what I think they'll do. They'll take a big axe to the Medicaid sections of the bill, because people who receive Medicaid are not in general supporters of Republicans. And here's another way to think about Romney's problem. He wants to get reelected. You can either govern through...
He hasn't even been elected.
Once he gets elected, if he does.
We're living in the theory.
If Romney simply governs through what some people would call the extreme right, he won't be reelected. It's not that popular a stance. So one possible strategy for Romney is, in the euphoria of having defeated Obama, if this happens, to immediately do something to deeply alienate the hard right, establish popularity with centrist voters, and then slowly over time, as re-election approaches, move back towards the right as campaign contributions matter again. And if you think you're Romney, how are you actually going to do this? Are you simply going to take every decision the way the most Republican members of the House would want you to? I don't think he's going to do that. There's nothing in his past record which suggests that. And there needs to be some break. You might as well do a break where you, in your own terms, get something for it. So that's my prediction.
So, the one thing I would say about this is that I think we should take a lesson from the recent past, which is every Republican campaign on repeal and replace, it was the #1 issue that they argued in 2010. But the truth is that the House Republicans had two anvils with the Obama administration. They had the government shutdown, and they had the debt limit negotiation. In both cases, they could have used they had a number of issues. It wasn't just one issue versus another. But if it was the #1 motivating issue for them, they could have used the government shutdown as an anvil on repeal and replace or repeal. And the truth is that what was the last issue being debated? It was actually Planned Parenthood. So it was not actually Obamacare at the end. Now, in the debt limit deal, there was an issue about the mandate, et cetera, percolating and less, but it was actually not repeal. That was, they made a decision. It's always a decision. They made a decision between revenues and Obamacare. And that was probably a rational decision for them. But they did choose another issue over Obamacare. And I would say just the issue for Romney is that he is the architect of Obamacare. So it is a complicated
At
world.
least a consultant.
The world, it's a complicated world we live in when he would be the person to undo it. And what he honestly feels about that, about Obamacare, I'm not trying to be negative. I just don't really know, because a lot of people in Massachusetts, I mean, Zeke and I both studied Massachusetts, he was very proud of it. I mean, and people around him argued that he knew this issue inside and out. In fact, I would say the best defender of the individual mandate in public life in the last 5 years has been Mitt Romney. I mean, he's argued it more effectively than any Democrat. So how that actually plays out, I can't really determine.
He even did it in one of the Republican debates.
In the Republican debates
Yeah,
recently. It
striking.
wasn't like 7 years ago or 5 years ago or 3. It was like in the last 2 years.
Zeke's a fan of bets, so after this panel, I'm going to design a bet on the idea of if Romney wins, what happens to the bill, and Tyler's going to pick the restaurant.
Zeke only likes bets that he organizes so he can win. It's not really.
Let's talk for a minute about the healthcare system, right? So we had a story on the front page of the New York Times a couple months back looking at the fact that healthcare cost growth has already slowed, right? And the article said this is not mainly because of the bill. The bill appears to play some modest role as people are trying to organize the healthcare system to get ready for the bill. It's mainly because of the recession. People go without healthcare in the recession the same way they go without fancy dinners and the same way they go without lots of things. But a fair number of experts also think the healthcare system itself is beginning to change, is beginning to reform of itself. Again, not mainly because of the bill yet, although the bill appears to be playing a positive role there. And there's some debate among healthcare experts of this. More optimistic ones think, yes, we're already starting to see, to use the term of art, the curve bend. We're already starting to see a reduction in the growth of healthcare costs because people are making different decisions. And more pessimistic ones say, no, it's all the recession. And when the economy comes back, the curve will unbend right back. I know, Neera, that you are slightly more pessimistic about it, right? Because we talked about it.
I wouldn't be wildly optimistic about what has happened so far.
Yes.
I'm more optimistic about what will happen in the future on this issue.
But so far, you don't think people are changing their behavior, doctors, patients, hospitals?
No. I think people are changing their behavior. I just don't think that we've been able to. I think most of it is attributed to the recession. But, I think we are seeing some. My concern in that article was that it was just a tad more optimistic than I think we should be as of this point. I do think that we are seeing some movement and positive movement, and we're seeing that every day and in different systems. The big challenge is we have really costly systems that continue, and we need to continue to push that envelope. I just want to emphasize one thing. I mean, we've had lots of discussions about competitiveness and American competitiveness over the next several decades. Zeke is absolutely right. The reason why this is so critical is that employment in the U.S. is constrained by healthcare costs, and it is a continual drag. And I would say, to put another hat on this, if healthcare costs are constrained, if we can realign these issues, some of the budget wars we've had between the Ryan budget, whole descriptions of what we need to do to Medicare as a program, the most live wire issues will actually be completely mitigated, because if we're actually able to get Medicare costs or healthcare costs under control, that will also lower Medicare costs, and that will, that would make the kinds of things that Republicans and Democrats have argued about, on the right, of voucherizing Medicare in 2020 past 2020, or whatever term we'd like to use, that would make this unnecessary. So I do think the real ball game actually is not in the mandate or the Medicaid expansion. As policymakers, the real ball game is in our ability to lower healthcare costs over the next several decades, really, and use the Affordable Care Act as it should have been used, as a leverage point to push those reforms to speed along even faster.
Tyler, you recently wrote a book about sort of stagnation writ large in the American economy and society. So I guess the question is, how optimistic are you that we'll escape stagnation in healthcare?
Here's my pessimistic optimism on healthcare. I think the economy has recovered. We just haven't recognized it yet. We haven't faced up to the fact that this is what recovery looks like, and it's not entirely pretty.
That's pessimistic, right?
That's pessimistic, but here's the quasi-optimistic side of that. If that's your view, then you are very likely to believe we have somewhat broken the healthcare cost curve. Now, the revenue projections and budgets still remain overly optimistic, but I actually tend to think we have seen a turning point, and it will stay with us. And at some point, when we get a much higher rate of what I call total factor productivity growth and a lot more innovation, then we'll be a lot wealthier and have broken the healthcare cost curve. So 20-year time horizon, I'm multiply optimistic. But on the healthcare cost curve alone, I'm optimistic right now, but only for bad reasons.
So, first of all, I do think that the recession has had a big impact. I don't think it's had 100% of, it's 100% explanation. I mean, healthcare cost growth has gone from 7, 8, 9% down to under 4% this past few years. The problem for all of us is 2 years is just too short to know whether this is a real structural change or whether this is just a temporary change out of the recession. The reason I think it's structural and going forward over the next decade will be structural is when you go out to hospitals and health systems, compared to what happened in the 1990s, everybody is figuring out how to do better. First, everyone's installing electronic health records, which alone won't change, but that, combined with lots of other stuff, will make a big change. Second, they're all working because of the law, reducing their hospital-acquired infections, their error rates, and lots of other things that are going to save money. They're all working to reduce their readmissions because of the law. They're all anticipating change in payment formulas and the need to bring their cost structure down. So they're all figuring out how do we re-engineer delivery. And I could go on and on. All of those things take time. But over the course of the next 3 to 5 to 10 years, so my time horizon is by 2020, we are going to have a transformed healthcare system where we are going to be delivering care in different ways. And we are going to structurally be saving a lot more money over time. And then, as Tyler says, we're going to be richer, and then we can tolerate a little more healthcare inflation. And let me say, those transformations out there, they're all going to benefit you. And I know many people who are well off don't think Obamacare has anything to do with them. And let me say they're wrong. First of all of you are going to have an electronic health record as a result of this bill by 2020, guaranteed. And it's going to be interoperable. You'll go to the Aspen Hospital or your hospital in New York or LA or wherever. Second, all of you are going to go to safer hospitals that are going to have less infections and less errors, and so that you can be a lot surer of the care you're getting. Third, you're all going to have a situation where doctors are better at focusing on chronic illness and better focusing on how to take care of patients who actually are sick and do a lot more coordinated care. All of those are pretty much guaranteed, and I could go on and on. But I think I know you don't think Obamacare has anything to do with you, but actually you're going to be big beneficiaries of the bill.
It reminds me of a story that Bob Wachter, who is a doctor and administrator at University of California at San Francisco, told me. He said when they first started thinking about error rates around their cardiac care, they went into it with the assumption of, well, we don't have a problem with that. We're UCSF. We're great. And they looked at it, and they had a pretty big problem with it. They're UCSF. They win Nobel Prizes. They do groundbreaking research. They weren't actually that good at getting someone who was having a heart attack from the door to error-free care in the cath lab. And so, I mean, it's really fascinating how much quality improvement there is to be had in this country at all levels.
Right. The one thing I would, just to bring this back to the court case, we spent about 5 minutes, maybe 10 even, talking about what we think is a central element to the bill, which is lowering healthcare costs. I would say something that I was relatively shocked by with the court case was that the Supreme Court had 4 justices who were willing to throw out the entire bill because of the Medicaid expansion and the individual mandate, which we could argue about whether the entire exchanges are operable based on the individual mandate or not. Some would argue, I mean, it's an important part, but you could still have exchanges. But they were willing to throw out all the work that is in the legislation around healthcare costs. And they didn't even address it. I mean, they didn't even talk about it in the court opinion. They talked about the employer mandate. They talked about the exchanges. They talked about the Medicaid expansion and the individual mandate. They didn't even address it. Would really be willing to throw it all out. And what I thought from that was it's just it was really scary another reason why I think a lot of policymakers were so concerned that this issue that should have really been resolved among policymakers was being litigated by the courts who are making law, not policy.
Does it change let's depart from healthcare for 60 seconds. Does it change your estimation of what happens on some of the other big issues before the court? Do you now think it's more likely the court gets rid of affirmative action next year?
Well, obviously there are a lot of people who think that Justice Roberts was giving himself a lot of leeway. I mean, there's now leaking out of the Supreme Court. So, which I've, you know, I went to law school and we worked on the amicus briefs. I'm shocked that there are parts of the conservative wing who are now leaking to reporters about it. But I'm going to continue to believe, perhaps falsely, that they will adjudicate law and make decisions based on interpretations of the Constitution rather than the politically expedient role.
Well, I'm not a lawyer. I did teach at a law school for one semester, which gives me authority to render this stupid opinion. But one of the things I think you saw in the immigration case and in the ACA is what I'll term, it's not a great term, a sort of Solomonic approach. So what you got in the decision on healthcare reform by Roberts was, you know, on the Commerce Clause, the conservatives are right. On the Medicaid, the conservatives are right.
Sort of.
And then you have, but the bill's upheld for the following reason. And I think you got that, so the conservatives get some of this, and then but the thrust of the bill goes to the president. On the immigration bill, you got pretty much the same thing. You know, the stop and ask for papers, that will uphold. The rest of it, we're going to affirm federal control over this area. Again, a sort of trying to cut the loaf halfway. But I do think, you know, Roberts clearly is worried about his legacy, and I think the reason he didn't want to overturn the law was his court would have looked like the most politicized court since the Dred Scott decision. But I think one should not think that his decision was not politicized. I think it's heavily politicized. Notice it does restrict the use of the Commerce Clause going forward. It does restrict how the federal government can incentivize states to do certain things. And as Neera said, it does immunize him to some degree going forward as not being the conservative political judge. So I think it was a very well-crafted, crafty decision.
There's not much tort reform in the bill, right? And that's one of the main that's one of the main complaints. How much, Tyler, could tort reform help?
1%? Now, 1%'s a lot. No one should laugh at 1%, and I'm all for doing that. But I think it's often overrated, and I think we'll see it in some form or another within 10 years. So, but there's a lot of medical mistakes, and I'm not sure malpractice suits discourage them, but it's not as if everything is fine and dandy and it's just a lot of, you know, crybaby patients. Malpractice reform is very tricky, it's very hard to get right, and a lot of people, I think, would actually regret it when we end up doing it. So,
because there's less accountability for doctors and
that's
hospitals?
right. I would support it, but very cautiously, and I would not want to oversell it.
So let me make 2 points about that, since I was very active for malpractice reform in the bill. The first is, make no mistake about it, the president was for malpractice reform. He really wanted malpractice reform. Prior to running for election, he actually wrote an article in the New England Journal of Medicine for malpractice with Hillary Clinton for malpractice reform. He has made clear he's not for malpractice reform that simply puts a cap on how much you can sue for. And I think the main reason to do malpractice reform has nothing to do with the money. Nothing to do with the money. I think Tyler was being a little generous on the 1%. It might be 0.5%. It might be 0%. It's small money. It's chicken feed as far as cost control. What it's really important for, doctors' psychological state. Because when I go out and I go to medical schools and I go to hospitals and I talk about healthcare reform, invariably one of the first 2 questions is, why isn't there any malpractice reform? Doctors have 2 good excuses before they begin to focus on what they can do to improve the system. The first is malpractice. I got to do X, Y, and Z that raise the costs or because of malpractice. And the second is those patients, they demand everything. They want the robot. They want the latest and greatest. You've got to get rid of those psychological crutches for doctors to focus on the real thing, which is how do they re-engineer care to make it safer, better, and higher quality.
I sometimes worry that a lot of our healthcare problem is cultural. It's not even so much doctors, it's not even so much incentives in the system, it's that we're Americans and our instinct is do more, try everything, never give up, do the latest, do the greatest, do the most, and that cultural instinct has enormous benefits, right? Enormous benefits. When it comes to having a cost-effective healthcare system, it's not so great. Do you buy that at all?
It's all true. It's why we'll always spend more than almost any other country per capita. That will never change.
I know, but I think that the issue here is the recession actually impacting this as well, right? I mean, the question is, it's not going to be true for everyone. People who can afford it are always going to ask for more and push for more. But you were seeing in a wide variety of arenas, people are recognizing that we live in a time of constraint. One of the reasons why we have lower costs is because people are consuming a lot less themselves. Perhaps there will be some, perhaps there will be some cultural shifts. And also another tragedy of the bill is one of the areas where we have a lot of costs are in end-of-life issues. Those issues were heavily politicized. Zeke could talk about that since he was, I think, Dr. Death Panel. But there are no death panels, et cetera. So I think that's also an issue where hopefully we can have those conversations culturally and change things culturally before the windstorm starts.
David, I think one shouldn't put culture in one category and incentives in a separate category. They intersect, and some incentives reinforce the culture, and some incentives undermine this culture of always more, more, more. And I think we can create a set of incentives that actually look for higher value care, that is, better quality care at lower prices, that will change the culture. There's no reason we can't get better technologies that are actually cost savings in healthcare the way we have in many other industries. The problem is there's no incentive to do it now. Under the future situation where we're paying doctors and hospitals differently, you will have an incentive to do things that actually can reduce costs, but give you great technology or better than technology, better medical care at a reduced rate. It's not like every technology, as I wrote for your paper, is necessarily better. We have a lot of technologies which people think are the latest and greatest, and they may be the latest and greatest technology, but don't add anything to your quality of your health care. You know, the Da Vinci robot for any man about to get prostate surgery, is four-arm robot. Every hospital advertises it as the latest and greatest technology. There's no evidence it's better, and there's some evidence it's worse. So yeah, it's great. It's technology, but it's not such great technology that it's a real advance.
And there's some of this work by it's a group in Boston, or the giving people more information. The idea, there have been some of these studies where when you really lay out in detail to people
the shared decision making.
Shared decision making. Thank you.
Yeah.
Lay out in detail to people the sort of risks and the benefits and the side effects. You see people choosing less intensive.
So what ends up
healthcare.
happening is there are scores of studies like this, and they almost all show the same thing. Give the people information. 10 to 20% of them will say, no, I don't want that procedure, whether it's a prostate procedure or a knee replacement or something else. And the bill actually has a sleeper clause about shared decision making, which hasn't been implemented by the government, to try to incentivize this, because we knew those data and we thought that they were really important. If you made every doctor, before he or she did a surgery or some other procedure, actually give to the patients, you will get 10 or 20% of people say, not for me.
Let's move to some questions. We have a couple microphones circulating. Is that right? What do we have? Okay. Let's start right here in the middle. And do we have a second microphone? Yep. Okay, great. So go ahead. Why don't you pick someone over there and right in here.
Hi. My question, first of all, I think it's a false argument to hope that Romney is joking when he says he's going to repeal the health care bill. The Republicans, when they say things, they're pretty serious about it. How do we convince people, like this crowd or my friends at home, that they need the health care bill and it is good for them, even though they have insurance, that it is good for them and their children?
So, I gave you several things that are going to be better for them if the bill gets passed. The electronic health record, safer hospitals, higher quality care. Their kids, keeping them on their plan till 26, which is now part of the bill, and while many insurance companies have said they'll keep it, who knows how long they would keep it. But also that security, that you have a mechanism separate from your employer to get coverage at a reasonable rate in the exchange, I think is a really important guarantee, whatever your pre-existing condition. Let me tell you an interesting fact that most people don't know. 10% of the uninsured make over 400% of the federal poverty line. They are well off and could buy insurance, and yet they don't seem to have it. Most of those people, it's not because they don't want insurance. It's because they or someone in their family has a pre-existing condition and they can't get it at any price. This solves that problem for them.
And I'd also say there are a number of ways in which the law also emphasizes preventive benefits. Preventive benefits in Medicare, the preventive benefits that you get just in the regular healthcare system that doctors have to provide you. And there's a prevention trust fund that is a little bit vulnerable to attack. But there is basically, we do have a broad problem in our system, which we've referenced a little bit, but we have an acute care system, not a healthcare system. We basically pay for every time you're sick. We don't pay for keeping people well. And there are a number of ways that we try to, the bill incentivizes keeping people healthy, both in the reimbursements increase for preventive benefits in Medicare, and there are also ways in which it's trying to get information out to doctors about what the best prevention methods are. So that's another way in which the bill does try to actually improve the entire healthcare system by ensuring that it moves away from the acute care model.
Isn't there some instant polling that shows the bill's already more popular?
Yes.
Is that right?
Yeah, also, and
but it's
Obama's
tricky.
numbers have flipped. But
Can you
that's temporary.
comment on Can you comment on the potential impact on medical education? I have a friend who's a dean of a medical school and says we're still teaching doctors as if from 1900 from a textbook from 1900. So
Yeah. Well, I've been convinced in my life that nothing moves more slowly than medical education.
Yes.
And it is true that most medical schools have not adapted. I wrote recently an editorial in one of the medical magazines that we should cut medical training by 30%. We could get rid of tons of medical school education and not harm the quality of the doctors we're producing. A lot of it is completely unnecessary. It's anachronistic. And even worse, in my opinion, there are lots of things necessary for them to understand about the financing of medicine, about how you measure quality, how you can re-engineer for quality that aren't being taught. I think there's going to become increasing pressure on medical schools as the decade goes on to really make a big break and to really do something innovative and novel. And Lord knows, I think they're going to have to do it. There are also some financial pressures that are likely to come to bear on them for not the medical school training, but the training afterwards, because that's likely to be cut in the next few years, and that'll focus the mind.
One issue on this is, and this is a broader trend that's not just for medical school, but medical school is kind of the crucible by which you can see it, which is, the entire manner in which people are taught in medical school really is for the idea of a solo practitioner making all decisions by themselves. And as we see technology permeate other areas and other parts of the economy, what we're seeing is one of the reasons we're hopeful about progress is that what is making and actually getting better value out of the system, the healthcare system, is that team-based approaches to medicine are incredibly effective, they produce value, and they make doctors actually happier. So that needs to permeate medical education. They need to change the culture, as David was referencing. But also, I think one of the ways that that'll happen is that doctors actually like to be in these approaches. They like salary over being solo practitioner. There are ways the culture is changing in a way that they like, and they're going to have a feedback loop to their schools when their alumni to actually shift that. And I think that will happen. It would be great if medical schools would adapt early instead of be dragged to it. But that is an area that's important.
It's interesting to look at, and let me see some hands again.
It's Peter. We have to call in Peter.
Go over here for one, and then we'll come up here for number two. It's interesting when you think about how healthcare is changing. A lot of this data collection, patients don't use at all.
Yeah, right. This is a huge issue.
The way in which it matters is doctors use it. Doctors hate the idea, wait a second, my hospital's ranked 7th in error rates, even if patients aren't actually going to check it and choosing based on it.
And just quickly on that, I mean, electronic medical records are great, but the way they increase value is they actually can provide you more up-to-minute information about what's wrong with you and what the best way to care for you is, which really informs, hopefully, consumers, but mostly doctors in what to do about it.
Guest questioner Peter Orszag.
Thank you. Actually, before I ask my question, just quickly, one of the things from one of the panels yesterday, Betsy Nabel, who runs Brigham and Women's in Massachusetts, indication of the changes that are occurring when asked what share of payments do you, in your strategic planning, your internal planning, what share of payments within the next 3 years do you think will not be fee for service, which is at the heart of the change? She said 100%. Within
Wow.
3 years, they are assuming all of their payments are some sort of risk payment. To the extent that that is being replicated at hospitals across the country, a huge deal.
Yeah, and Massachusetts is very expensive.
Now my question. Let's speculate about what will happen if a Romney victory and then a Republican sweep. Because it strikes me you can't analyze what will happen in a repeal scenario in reconciliation without taking into account other things that will have to happen in reconciliation. And I suspect, this is just a guess, but I suspect the most attractive thing that will be part for those newly elected Republicans is block granting Medicaid. They have to do something big. Block granting Medicaid is big. You can do it in a way in which you put upfront payments at a higher rate to start with, and then you flatline them so that it looks great for the federal government, and governors will, facing a $50 billion aggregate deficit at the state level, perhaps find that attractive. So the question is, how do you evaluate? The Supreme Court decision then becomes kind of irrelevant because Medicaid's fundamentally different, at least along that dimension. Could you evaluate whether you think I'm crazy, or at least along this dimension? And secondly, if that is actually ultimately done, what impact it has?
Tyler, you go
This is
first.
exactly what I think will happen. And furthermore, if Romney does not win, I think there's a very good chance it will happen over the next 10 years anyway, under the U.S. system of government. So I think the political tendency is that old people win all battles, and as budgets get tighter, funds will be reallocated from Medicaid to Medicare, often in ways which are not value enhancing. And my 5-word theory of American politics, like old people always win, is a pretty good theory.
Well,
And I wouldn't focus too much on Romney, though I think that is exactly what they would do.
But as you know, the challenge with Medicaid is that the biggest growth in Medicaid, what costs the most in Medicaid, is long-term care for seniors. So the challenge that exists in Medicaid is that when when people realize that the only thing that helps them deal with those long-term care services comes through Medicaid, not through Medicare,
That's the
especially
part
with
they'll
the
keep
class.
now.
Yeah, I mean, it's possible. I guess, that would be an interesting world we lived in which we kept the Affordable Care Act and denied, for middle-income Americans, working Americans, and denied coverage to poor children, pregnant mothers, some families. I mean, I guess we could live in that world, but it would be a hard world to live in.
I think, Peter, if that eventuality comes to pass, and those of us who really care about people getting coverage and not wanting to see states take the block grant and then screw their population, their poor population especially, what you would have to focus on is what are the metrics that they'd have to comply with to continue on the program, and what quality and access metrics. So I think Democrats will need a strategy for that approach. And I agree with, I think the one thing which is sort of worrisome about that is fiscally for the federal government, it'll look great, but it transfers the risk down to the states. And I think we're going to see a lot more states either teeter on insolvency or actually go belly up, and it'll make Stockton look like just a small end of the wedge.
First of all, with respect to Justice Roberts, I think it's worth noting that I don't think Justice Roberts really bought the taxing clause argument. I think he was actually extremely conservative in his opinion, and he was simply trying to exercise judicial restraint and transfer the power to pass this kind of legislation to the Congress, and he hung his coat on it. Moving on and he quotes Justice Holmes, I think, in the opinion to that effect. I'm surprised that we're celebrating a decrease in the rate of increase in medical cost. In other words, I think it was said that the rate of increase of medical cost is down to 4%, but we have a 1.9% GDP, which means that medical cost is still increasing faster than GDP. And my question is, where do you think we get to in 10 years' time, medical costs as a percentage of GDP, and how do we get to 11 or 12% like some of our neighbors are, so that we can be competitive?
I'm actually going to take a very quick crack at that, and then go ahead. Just philosophically, I think it's important to keep in mind, and you didn't say otherwise, but it's important to keep in mind, healthcare growing as a sector of the economy over time is not only okay, it is good. Think about a rich society, right? Think about a rich household. You've got 2 cars, you've got 4 TVs, you've got a VCR, and then you got an extra $100. What do you want to spend it on? Do you want to buy another VCR, or do you want to spend it on your health? Right? And that is why over time, for rich societies, healthcare grows as a share of GDP, and it is natural for it to grow as GDP, right? Okay, but now to your question, which is how high do we get in? Can we ever get, I mean, we're so much higher than any other society.
Steady state, 40%. We'll love it. The other stuff doesn't make me happier. And someday the stuff will actually start to work. I mean, that's the miracle.
So 40%, I'm not sure where someday
Where are we now, 17?
18.
18. And other rich countries are at 12.
Right. So
The most
when we
rich,
talk
second.
about cost control, sometimes I slip and say cost savings, but we're not going down. We're not going from $2.8 trillion, which is what we'll spend in 2012, down to $2 trillion. The question is, how slow does it go up to $3.5 and $4 trillion? And that is a very important number, because as the GDP grows, as David said, we are going to spend more. There's very good correlation across all rich countries that happens. But the issue is, how slow can we get it? For a brief, shining 5-year period, 1993 to 1998, we actually got relatively steady state, keeping it at about 18%. My guess, and this is just pretty crude, we'll get to probably 22% over 10, 12 years, and then, I think we'll probably flatten it out, assuming we get, and Peter prefaced what he said, assuming we get consistent changes in payment by the end of the decade.
Can I just reference the Roberts? What I thought was fascinating about the Roberts opinion writ large is that, on the Commerce Clause, where we have, a lot of jurisprudence that essentially argues that since the New Deal, the Supreme Court is not going to second-guess large-scale economic decisions by the Congress. There's like no judicial difference to Congress in the Commerce Clause jurisprudence. I mean, you read through the case, his attitude towards congressional action is one of, contempt is too strong a language, but it is with deep skepticism. A skepticism that I would argue no majority opinion has had against anything that touches economic activity in 100 years, or close to 100 years. So that is, you're absolutely right. His language around the taxing clause is essentially like, it could be constitutional, so I'm going to find it constitutional. I'm just saying that was not the attitude towards the Commerce Clause. He certainly didn't have the attitude, it could be constitutional, so I'm going to find it constitutional. And again, the dissents, the 4 conservative dissenters, did call him on that. And I think on that one issue, they were right. But my view is that it was an oddity for him to create essentially a new precedent that, if you read through the opinion, does not have a lot of precedents behind it. A new precedent that limits activity under the Commerce Clause.
Let me say, this adds one other element to why this election is going to be a monumental election, maybe one of the most important in 100, 150 years, which is you're going to have probably at least 2 justices retire, and maybe 3, and whoever's president is going to appoint them. So in addition to all the other stuff that is going on, implementation of Dodd-Frank, implementation of the health care bill, all the other things that are going on, Supreme Court is going to be reshaped.
There should be a panel next year about why Supreme Court justices don't retire early and aren't more strategic about it. Because if you think about, Supreme Court justices take enormous risk with their own beliefs. Ma'am.
Absolutely. I think it's power.
I heard that the number of applicants applying to medical school is decreasing significantly, and the quality of those applicants is also decreasing. Now, if that's accurate, I heard it from a panel, And if that is accurate, how is the system going to handle it with the more and more people that were going to the emergency room with the mandate now having insurance, needing primary care physicians, and there not being enough? How's the system going to handle it?
So there are two parts to your question. One is, have the applicants to the medical schools gone down? To the best of my knowledge, it's not true. Actually, I think they've gone up because of the recession. And people going away from business school. So I don't think that's actually accurate. The second thing is, there is a question about workforce. And if we add in 30 million people to the system, can we actually handle it? And the short answer is absolutely. And let me give you a few reasons. One, Neera actually pointed to, which is increasing working on teams where there are lots of things that I do as a doctor that I don't have to do that a nurse could do, or even a health aide who doesn't even have medical training can do. We're going to see increasing use of that because it makes no sense for me to be doing a lot of those things. The second piece of information I would suggest to you is a lot of what we do, repeat visits. So I'm an oncologist. When my breast cancer patients come back right after we finish chemotherapy, they come back. I schedule them for 3 months for the first year, and then 6 months. Where did 3 months come from? It's hocus pocus. No one has any data that makes any difference, and there's lots of reasons it shouldn't make a difference. And so you're going to see a lot of change in how we handle that. And the last thing I would say is, if you look at Massachusetts, where they brought 500,000 people into their state, no change in waiting times at primary care doctors, no change in waiting times at cardiologists, no change in waiting times at obstetricians. That's not data from some left-wing nuts. That's data from the Massachusetts Medical Society.
They might be left-wing nuts.
I know that.
One last question, sir. You've had your hand up almost the whole time.
I'm Norm Ornstein from the American Enterprise Institute. I have a question mostly for Tyler, and it follows a bit on what Peter said. Imagine that Republicans take the House, Senate, and the White House and pass what Paul Ryan has called the mother of all reconciliation bills. That means that we make the Bush tax cuts permanent, cut the top rate to 25%, cut Medicaid by 30%, and send it back as a block grant to the states. It would cut out the tax on the health care mandate, and also probably cut out funding for much of the rest of it, along with a whole series of other changes. What do you think the odds are that Mitt Romney would veto that bill?
Great
You're the
question.
conservative.
Great question.
I think he is skillful enough not to get into that position in the first place. And there are enough Republicans who want to be reelected that they would, in a quiet way, support Romney. And I think a lot of what you mentioned is what would happen. I don't think it would be a 25% rate. That sounds too low. But the Bush tax cuts would be continued and made permanent. But I think there needs to be some kind of healthcare policy put on the table, and it will be radically relabeled, but cost control will be kept. Cuts to Medicare, or potential cuts to Medicare, will be done away with. Medicare will be firmed up. That will be sold to Republican and elderly voters. But parts on the right will take a real hit, and I don't think the full-blown Ryan plan will ever happen.
I would just say I've been waiting for the silent majority of Republicans for a little while here over the last 3 years, and it's been difficult to see them on these policy issues. So I hope you're right.
Sounds like Norm's on my side of the bet. Thank you all.
Thank you
all.